I'd like to thank
الدكتور عمرو ابو المجد فين
event special Dr.
والدكتور حازم حكيم
decision. My case is
الدكتور احمد الزمزمي.
managed by EUS Cystogastrostomy. As we know, acute pancreatitis can be interstitial or necrotic. Interstitial pancreatitis can result in acute pancreatic fluid collection. This collection may form pseudocyst after 4 weeks after developing of the wall, mature in up to 4 weeks, and usually it has a minimal amount of necrosis. Pseudocysts tend to resolve spontaneously without any intervention, and they need intervention only if the patient is symptomatic. We know that there is many modality for pancreatic pseudocyst management, like percutaneous, surgery, and EUS. Endoscopic ultrasound guided drainage has become the cornerstone for the management over percutaneous and even for surgery, over surgery, except in certain situations. Our case, 28-year-old female complaining from vomiting, gastric pain, and jaundice. The serum bilirubin was 3.5 milligram per deciliter, mainly direct. She had history of laparoscopic cholecystectomy months before the symptoms. Complained from epigastric pain and vomiting. Radiology revealed epigastric collection that management by percutaneous drainage, percutaneous tube, but recurrence occurred with worsening of symptoms plus jaundice. The patient referred for us for EUS assessment. EUS evaluation showed unilateral pancreatic cystic lesion related to the pancreatic head, compressing the distal part of the CBD, dilated CBD up to 10 millimeter in diameter. There is no connection to the cyst, but only compression. The pancreatic duct was normal caliber, but echogenic wall, hyperechoic wall. The pancreatic parenchyma showed some lobulation and echogenic strands. We aspirate amount of this fluid for biochemical analysis that showed high level of amylase and low level of DA. So we decide to do EUS guided cystogastrostomy. First, evaluate the cyst from the stomach. The commonest and the preferred site for drainage. The cyst is relatively large, about 9 by 11 unilocular, with little amount of debris. But when we measure the distance between the gastric lumen and the cyst, it is quietly large, thick, more than near 2 centimeters. And so we decide to search for another thinnest distance. We found it through the duodenum, and so we decide to do the procedure transduodenal. We short the scoop like in ERCP to make the use of the accessory easy, and it changes the accessory rapidly and easy. We apply the Doppler, and then we puncture the cyst. with 19 gauge needle, aspirate a little amount of fluid, and then introduce 0.035 ERCP guide wire, making more than one loop in the cyst. And the important message here is to maintain the guide wire in the EUS view over the procedure. This makes the procedure easy and short. Then we create the tract using coaxial cautery using a cystostome, and then dilute the tract using the balloon. We can see under EUS fluoroscopy and even endoscopy, but we didn't need the endoscopy. We can do under EUS and fluoroscopy. The second message here is to how to choose the balloon, or what is the maximum extent of dilatation. It depends on the site of drainage. The transesophageal route, which is not recommended, we dilate only for 4 up to 6 millimeter using 4 or 6 millimeter balloon, not more. If we decide to do transduodenal, we can dilate from 6 to 8 millimeter. If we do transgastric, which is the commonest and the preferred route, we can dilate from 10, 12, or up to 15 millimeters. This is for plastic stent. If we decide to put lamps or metallic stent, we dilate only for 4 to 6 millimeter dilatation. So the size of the balloon depends on the site of the drainage. Sorry. After that, we deploy this, we insert the stent over the guiding case. We did this last step under the shortest stent we have is 7 millimeters, so we use it. Start gradually to push the stent. I think this is the distal mark of the stent, the distal mark of the external coil, external. We gradually withdraw the scoop while deployment of the stent. Withdraw the scoop towards the pylorus gradually, and gradually deploy the stent. Deploy it, but unfortunately I lose the guide wire. We check the stent position again. It is internally migrated, the hole to the cyst. The stent migrated internally to the cyst, so we rapidly cannulate the cyst again directly with the guiding cap over the guide wire, and start slowly to insert a second big tail stent, 7 centimeter 10 French. This is the first mark, and this is the second mark. And now I try to withdraw the scoop towards the pylorus gradually while deploying the stent, maintaining the wire inside. Slowly slowly maintaining the wire and go back to the pylorus. Finally deploy it. The guide wire here. So I'm sure that the stent is outside. I remove the guide wire. And this is the last result. This is a transmural stent, and this is the internally migrated stent. Follow up the patient after the procedure. There is no pain, no fever within 2 days after the procedure. Marvelous response regarding the symptoms. The jaundice subside and the pain, vomiting also subside. 1 month later, the cyst by ultrasound is resolved completely after 1 month. Message for EUS cystogastrostomy: it is an easy maneuver, but we try to keep this message in our mind to make it so easy. First, try to have a straight scoop position to make the use of accessory easy, and also exchange the accessory easy. Try to have the shortest distance between the cyst and the lumen to decrease the incidence of complication, especially perforation and peritonitis. Before puncturing, apply Doppler to decrease the incidence of bleeding. To make the procedure easy and short, maintain the wire on the EUS view all over the procedure. We recommend to use 6 French cystotome for creation of the track, associated with faster procedure, and also decreased rate of complication. The size of the balloon depends on the site of the drainage. Transesophageal, choose the smallest balloon. Transesophageal, 4 to 6 millimeter. Transduodenal, 6 to 8 millimeter. Transgastric, we can reach to 15 millimeter balloon. The most important message in our case is to never to remove the guide wire until the accurate placement of the stent is confirmed. Lastly, I need your opinion. In our case, what we can do for this migrated stent, the internally migrated stent. To dilate and remove the stent in the same session, dilate and remove it after 1 to 2 weeks, or to dilate and remove at the time of transmural stent removal. Have any other suggestion? Thank you.